Good morning. Um, the Dallas CVI annual meeting is a celebration of all the healthcare providers in Dallas-Fort Worth Metroplex. As an RN faculty, I invite you all, most especially all the nurses, for without their support, none of the patient care endeavor would be successful. Thank you.
Anand, if you'll please. All right. I want to thank all the organizers, especially Dr. Brolakis and Banerjee, for inviting me here today. Here are my disclosures. So this might seem like a very mundane topic to begin the symposium off with, stable CAD. But I would contend that it's quite an important topic, and not just because I'm up here giving it. But as we move forward, there's increased emphasis on cost containment, particularly as it relates to cardiovascular procedures. And this is coupled with a growing evidence of the limitations of PCI for stable coronary disease. Furthermore, as we all know, there's increasing public and press focus on the overuse of PCI. And this latter point should be troubling to all of us. For almost every month, you look in the newspapers and on the internet, you see that there are attacks on the use of cardiac procedures, particularly coronary stenting. Heart stents still overused, experts say. Deaths linked to cardiac stents rise as overuse seen. And in fact, some individuals have been publicly flogged for their overuse of stents, often in graphic detail. And a few individuals have actually ended up in federal prison for their revascularization practices. And in fact, more and more, our practice patterns are becoming part of the public record. For instance, individuals in the lay public, they can go on the internet and they can look county by county, city by city, at how many PCIs are done in their particular area. So for example, in Dallas, there are 5.3 PCIs per 1,000 Medicare enrollees. And that's below the national average. Despite having the Dallas VA here, we're still well below the national average, so you guys are safe in Dallas. But nonetheless, the point I'm trying to make is that what we do is part of the public awareness and public record. But is PCI being overused? Are stents being implanted out of control? Well, if you actually look at the rate of cardiac stent procedures over the past decade, there's actually been a decline in the number of stent procedures. We see that in 2003, with the advent of drug-eluting stents, there was a robust use of coronary stents. And then around 2006, we became aware of the potential for stent thrombosis, and there was a decline in coronary stent implantation. Then, with the publication of the Courage trial, there's been more or less a plateau of stent use. And when you look at the current treatment of coronary artery disease, you see that the vast majority of patients are still treated medically, with a minority undergoing revascularization therapy with either PCI or coronary artery bypass grafting. Furthermore, when you look at the indications for PCI in the United States, the majority are done for acute coronary syndromes, which certainly have a stronger indication than those for stable angina. But lost in all of the hysteria is the fact that stents actually save lives and they reduce morbidity, particularly when you look at the clinical scenarios of STEMI, non-STEMI, and shock. The interventional societies are playing catch-up, and they're trying to educate the public about the value of coronary stenting. And so Sky, for instance, has introduced secondscount.org, which helps educate the public about the benefits of coronary stents, particularly as it relates to acute myocardial infarction. Furthermore, the ACC has attempted to help practitioners by keeping them within the guidelines, and the appropriateness criteria were introduced. And basically what these criteria allow an individual to do is to look at a patient's symptoms and then figure out if a particular strategy for PCI would be appropriate, of uncertain appropriateness, or inappropriate. Now, inappropriate is a very strong word. It's often associated with public figures, with infamous world leaders. It's not a word we want thrown around in medicine. Furthermore, it's a term that a plaintiff's attorney would love to grab a hold of. So more recently, the ACC has then moved from inappropriate to rarely appropriate. In contrast, the European guidelines have been more traditional, and in the most recent iteration, they've divided indications for PCI into those which improve prognosis or those which improve symptoms. And those two categories form the basis of our strategy for stable coronary disease. So ideally, we want to take a patient who's symptomatic, has angina, and make them asymptomatic. More difficult is what to do with the patient who's asymptomatic but has ischemia present. And we can hypothesize that if we revascularize those patients, we may get a prognostic benefit. So we have a few key questions to address. First, when do we favor optimal medical therapy as an initial strategy over PCI? When should we consider revascularization with PCI? And when is Cabbage the preferred strategy over PCI? So let's address these questions. First, let's take a look at what the guidelines would tell us. In low-risk patients, those with mild symptoms, low-risk features, we can certainly begin simply with a trial of medical therapy. With those patients who are intermediate risk, mortality rates 1 to 3%, moderate symptoms, clinical risk factors, we should, of course, begin with medical therapy, but we should consider coronary angiography. And what I tell my fellows is that there is a danger in moderate or high-risk patients of not knowing coronary anatomy. In fact, the trials which have compared medical therapy to revascularization have all had some assessment of coronary anatomy. And these are 3 examples of patients within the last few months that I've performed an angiogram on for stable coronary disease and turned out to have significant left main stenoses. So then in your high-risk patients, the ones with high-risk features, medical therapy along with coronary angiography. What about revascularization? When do we choose to revascularize patients? Much of our decision-making was brought into focus by the infamous Kurdish trial, published in 2007. And the Kurdish trial asked the question, in patients who have stable coronary disease, is a strategy of initial optimal medical therapy better than medical therapy plus PCI at reducing cardiovascular events? And the primary outcome was a composite of death and non-fatal MI. And what did we find? What we found in the Courage trial was that PCI added to optimal medical therapy did not reduce the long-term rates of death, MI, or future ACS. Anginal relief was better with PCI early, but at 5 years was no better than medical therapy. But the question you have to ask yourself is, how courageous was Courage? We knew much of these data from earlier studies that were smaller, but nonetheless, we knew much of these data ahead of time. We knew that medical therapy is effective in stable coronary artery disease. Furthermore, there are several caveats and criticisms to the Courage trial. First of all, optimal medical therapy in Courage, or in any randomized controlled trial, may be difficult to achieve in real life. Again, knowing coronary anatomy may have led to selection bias in terms of enrollment of patients. The population in Courage was relatively low risk for events to begin with, and there was an unusually liberal definition of periprocedural MI, which likely biased the study against PCI. As opposed to modern therapy less than 3% of patients received drug-eluting stents, and there was a relatively high crossover rate in the medical arm to PCI. So I would contend that Courage was not really all that courageous. It certainly confirmed the findings that PCI for stable patients is unlikely to reduce mortality, and it reaffirms the importance of medical therapy in these patients. On the heels of the Courage trial came the Barry 2D study, and this was a randomized trial of over 2,000 patients with type 2 diabetes and stable coronary disease. And the patients were either randomized to prompt revascularization therapy plus medical therapy or medical therapy alone with deferment of revascularization if needed. And about 40% of patients ended up needing deferred revascularization. The primary endpoint was all-cause death. A couple of points, no left main. So these studies have all really excluded left main coronary disease. Relatively stable heart failure patients, you couldn't have 3 or 4 class heart failure. And only a third of patients in the revascularization arm actually got Cabbage. Most patients got PCI, and most patients got bare metal stents. And what the authors found was that revascularization did not improve survival in stable patients with diabetes. But it's important to understand that most of the revascularization patients underwent PCI, and 40% of those patients had stents placed for single vessel CAD. And why is that important? So you're unlikely to show a mortality benefit if you have single vessel coronary artery disease, whether you get revascularization or not. And though many have made assumptions about Cabbage versus PCI with this study, it was not designed for Cabbage versus PCI. That was left up to the individual operators. So we can't conclude any differences about Cabbage or PCI from the Barry 2D trial. So the Courage trial and Barry 2D, they relied on anatomic definitions of coronary artery disease severity. And now moving forward, we know that there are limitations to that. So maybe the presence of ischemia is the key to deriving a benefit from revascularization. And how would ischemia confer risk? Well, we know that moderate or severe ischemia is a marker for higher rates of mortality. But what's unclear is whether this increased risk of death is a direct effect of the ischemia, is the result of subsequent occlusion of a tight lesion, is the nidus for arrhythmogenesis, or whether severe ischemia is just a marker for more severe atherosclerosis. Nonetheless, our primary basis for going after ischemic lesions in people who are relatively asymptomatic comes from a very early trial, the Aesop trial. Had under 600 patients, published in '97. And in this study, patients had obstructive CAD and objective evidence of ischemia. And they were randomized to one of 3 strategies. In one strategy, they received medical therapy till their angina was better, if they had angina. In the second arm, they received medical therapy until the ischemia was better. Or in the third arm, they went ahead and got revascularization therapy. So what we found when we look at the results of the Aesop trial is that the lowest mortality was in patients who got revascularization therapy, as compared to the other 2 arms. However, we have to understand that this was a relatively small trial. And in general, the findings of a mortality benefit in stable patients have not been reproduced or confirmed in subsequent trials. More contemporary data would come from the Courage study, and there was a subset of the Courage trial in which about 100 patients with moderate to severe ischemia on non-invasive testing returned for a second non-invasive test 6 to 18 months later. And so there was a chance then to study the change in ischemia over time. And what the authors found in this subset study was that PCI reduced ischemia better than medical therapy. For both groups, the medical therapy arm and the PCI arm, if you could reduce ischemia, you had fewer events. So getting rid of the ischemia was good. But did PCI reduce events compared to medical therapy? And the answer was PCI did not reduce events in patients with moderate to severe ischemia. So maybe the way we're assessing ischemia is the problem. Maybe we need a better assessment of ischemia. And certainly one of the emerging gold standards for ischemia assessment is fractional flow reserve, or FFR. So the FAME-2 trial used that as the basis to study patients who had stable coronary disease and were planned for 1, 2, or 3 vessel drug-eluting stent PCI. And patients got FFR in all lesions, and in the randomized subset, patients were randomized to either PCI with medical therapy or medical therapy alone. And what the authors found was that FFR-guided PCI had a substantial benefit in the composite endpoint of all-cause death, MI, or urgent revascularization. But this was solely driven by urgent revascularization. In fact, it was driven by a soft definition of unstable angina, with fewer patients having frank MI or ischemic changes. So really what it showed was that you reduce the need for urgent revascularization, but there were several issues. Again, if the primary endpoint of Courage and Barry 2D also included urgent revascularization, there would have been no significant difference between the two arms. So the fundamental question is, if clinical trials in the modern era show no clear death or MI benefit as an initial strategy of revascularization, do we need to cath and revascularize patients prior to giving them a trial of medical therapy? And this is what the Ischemia Trial will address. And the hypothesis is that an initial invasive strategy of cath and revascularization, either with PCI or Cabbage, is going to be superior to a conservative strategy. And this trial will avoid many of the prior design limitations. It will exclude the low-risk patients. It will reduce referral bias. It will use modern DES, FFR, and heart team approach. And it's interesting to note that the #1 enrolling site is here in the United States with Dr. Banerjee at the VA. So hopefully, once we get these data, we'll be able to answer these important questions. To wrap things up, I want to just touch upon Cabbage versus PCI. Most of us here have heard of the Syntax trial. This was a large trial comparing Cabbage to Taxus drug-eluting stents. Essentially, more than half of patients had stable angina. And what the trial found was no mortality difference between the two strategies, higher repeat revascularization with the PCI arm, and a higher stroke rate with the Cabbage arm. More importantly, what we were able to take away from the Syntax trial was that not all patients are the same. By using something called a Syntax score, we can delineate whether patients are better suited for Cabbage or PCI. And those in the high Syntax score with high degree of anatomic difficulty are better suited for coronary artery bypass grafting. To finish up with diabetics in the Syntax trial, they had a much higher MACE level, major adverse cardiac events, if they got drug-eluting stent placement versus Cabbage. So that piece of data really leads us into the FREEDOM trial, which is the most recent trial comparing stents or surgery. And what the FREEDOM trial essentially showed was Cabbage was of significant benefit compared to PCI in diabetes with advanced coronary disease. So some final take-home messages related to stable CAD. First, optimal medical therapy is the cornerstone for management. It's reasonable to refer patients for coronary angiography if they are intermediate or high risk. PCI for stable angina should primarily be driven by symptoms, despite optimal medical therapy. The role of ischemia in guiding PCI is unclear, but FFR may be helpful. And for complex disease, complex anatomy, Cabbage is preferable to PCI. And certainly in diabetics with complex disease, we should consider Cabbage. So with that, I'll stop. Thank you.